In the next section, we will look at GI peptides and hormones and the pivotal role that they play in gastrointestinal physiology. The next module of GI physiology will be looking at GI peptides and hormones. This is an important section because these are easy to test and often come up in the USMLE exam. First of all, we need to understand the characteristics of GI peptides. There are different types of hormones that are released. These can be endocrine hormones, which are released into the portal and then systemic circulation, and their stimulation is downstream. There are paracrine hormones, which stimulate adjacent cells, and neurocrine hormones, which are released by a nerve to stimulate a non-neural cell. Autocrine hormones represent the fourth type, and they stimulate themselves. The true hormones that are present in the GI tract are gastrin, cholecystokinin, secretin, and glucose-dependent insulinotropic peptide. This table represents a good overview of each of these hormones, and we will discuss them in further detail. Gastrin works to stimulate acid secretion by the gastric parietal cells directly and indirectly. This does so by releasing histamine from the enterochromaffin-like cells, or ECL cells. Gastrin stimulates growth of gastric oxyntic gland mucosa, so it's also a trophic hormone, i.e. it stimulates growth of other cells. Low pH inhibits G cells. This is important because as gastric acid secretion takes place, and when there is enough gastric acid present, the pH in the stomach goes down, and therefore a negative feedback mechanism is present to prevent further secretion of gastrin. In the Zollinger-Ellison syndrome, or a gastrinoma, there's a gastrin-secreting tumor. This is often congenital, is present in the head of the pancreas. This results in the secretion of acid. As gastrin is a trophic hormone, it results in the hypertrophy of gastric mucosa. However, there is no negative feedback mechanism as this is a tumor, and therefore this hypertrophy continues. Duodenal ulcers will be present, and pancreatic lipase inactivation also occurs because there is acid present in the duodenum which would normally not be present, and so digestion of fats is impaired. This therefore results in steatorrhea. Gastrinomas such as associated with Zollinger-Ellison syndrome are treated with H2 receptor blockers or proton pump inhibitors. Vagal reflexes also stimulate gastrin production and play an important role in acid secretion. Historically, in patients presenting with peptic ulcer disease, a vagotomy was often the therapy of choice, as this was one way of reducing gastric acid secretion. With vagal reflexes, neurocrine is released from vagal nerve endings onto the G cells, and this is gastric releasing peptide. So GRP is released on vagal stimulation and results in gastrin secretion and subsequently acid secretion in the stomach. Cholecystokinin is the second true hormone and is secreted by the eye cells of the duodenum and jejunum. Its release is stimulated by fatty cells or their monoglycerides, and this represents the most potent stimuli for secretion. Release is also stimulated by small peptides and amino acids. Therefore, as food leaves the stomach and enters the duodenum, cholecystokinin secretion is stimulated, and cholecystokinin is important as it facilitates fat digestion. It's structurally related to gastrin, and in fact cholecystokinin and gastrin are thought to come from the same family. Cholecystokinin secretion stimulates gallbladder contraction and relaxation of the sphincter of Oddi. This therefore results in the release of bile into the small bowel, and the importance of this will become apparent later. In cholecystitis, ingestion of a fatty meal produces pain. This is because if gallstones are present in the gallbladder, resulting in an obstruction of biliary flow, inflammation can occur. As with the one rule that occurs in the body is that there is stasis of flow for any reason, infection or inflammation ensue. Therefore, with cholecystitis, if biliary flow does not occur, an infection can occur. When a fatty meal is taken in, cholecystokinin is released. This results in contraction of the gallbladder to release bile, but as there is inflammation there, this produces pain. Cholecystokinin is a potent stimulant of pancreatic enzyme secretion of both lipase and amylase. It also potentiates secretion of bicarb stimulated by secretin. This is important because gastric acid impairs or inhibits pancreatic enzymes. Therefore, cholecystokinin acts to potentiate the secretion of bicarbonate by secretin, therefore neutralizing gastric acid, which may come down from the stomach. Cholecystokinin is another trophic hormone and can produce growth of the exocrine pancreas and gallbladder. It also plays an important role in inhibiting gastric emptying or increasing gastric emptying time. This becomes important because this means that there's a controlled release of food substances from the stomach into the duodenum, and therefore gastric contents and gastric acid does not overwhelm pancreatic lipase and amylase present in the duodenum. Secretin is the third true hormone of the GI tract. It's secreted by the S cells of the duodenal mucosa when it's contacted by acid and fatty acids. It's structurally similar to glucagon, and the most important stimulus for its secretion is acid with a pH of less than 4.5. Therefore, when gastric contents come into the small bowel or duodenum, S cells are contacted and secretin production occurs. The primary effect of secretin is to stimulate pancreatic bicarbonate and water secretion. Therefore, they act to neutralize the acid that is present in gastric contents. Secretin can also stimulate growth of the exocrine pancreas. Another effect that it has, as well as neutralizing acid in the duodenum, is to inhibit further gastric acid secretion. All of these factors combine to present an optimal environment for pancreatic enzymes to work in the duodenum and jejunum. It's produced by the K cells in the duodenum and jejunum, and is homologous to secretin. It stimulates insulin release by pancreatic B cells in the presence of glucose. Hence the name glucose-dependent insulinotrophic peptide. It's the only hormone that's released in response to all three types of nutrients, namely glucose, protein, and fatty acids. This is something that can be tested very easily, and it also inhibits gastric acid secretion, although that's not its primary function. There are other peptides that are present, namely metillin, pancreatic polypeptide, and enteroglucagon, and we will talk about these further as well. Metillin is secreted by the enterochromaffin cells and Mo cells in the stomach, small intestine, and colon. It's released approximately every 90 minutes to 100 minutes in the interdigestive state, i.e. during times when we're not eating. And it's a major regulator of what's known as the MMC, or the migrating motor or myoelectric complex. The MMC is a way of making sure that contents in the GI tract that have not been carried along by peristalsis have a way of getting through the GI tract. And this is a way of thinking of cleansing the GI tract and making sure all products reach the large bowel. Pancreatic polypeptide inhibits pancreatic secretion of bicarbonate and therefore directly acts as an antagonist for secretin. Enteroglucagon is released from the intestinal cells in response to decreased blood glucose, and therefore stimulates hepatic gluconeogenesis and glucogenolysis. This occurs in the liver because the liver is the main store where these mechanisms can take place. Gastric releasing peptide, or GRP, historically known as bombesin, is present in vagal nerve endings and is released by vagal stimulation and mediates vagally stimulated gastrin release. As I mentioned earlier, this is the reason that historically vagotomies were a way of trying to reduce the amount of gastric acid production before the advent of H2 blockers such as cimetidine and ranitidine, or proton pump inhibitors such as omeprazole, esomeprazole, and lansoprazole. Enkephalins, which are present in the GI tract, contract smooth muscle and are potent inhibitors of intestinal fluid secretion. PYY, or PI, inhibits gastric motility and results in a reduced appetite. Ghrelin is produced mainly by cells lining the fundus of the stomach. It stimulates hunger and is found in high levels in obese patients. It's reduced following bariatric surgery for unclear reasons and may play a role in the dramatic weight loss that is often encountered by these patients. The paracrines that we will talk about in this lecture are somatostatin and histamine. Somatostatin is secreted by D cells in the GI mucosa. Decreased luminal pH stimulates somatostatin secretion, and somatostatin is a pan inhibitor. Namely, it inhibits release of all gut hormones: gastrin, cholecystokinin, secretin, motilin, VIP, and GIP. It directly inhibits acid secretion from parietal cells as well as motility, and therefore acts to decrease pH. Vagal activation prevents somatostatin release, and we know, as has been discussed, that vagal activation also results in increase of acid secretion. Histamine, which is another paracrine, is not a peptide. It's secreted by the enterochromaffin-like cells, and gastrin also stimulates release of histamine. This is why H2 blockers or histamine receptor blockers such as cimetidine and ranitidine are effective in reducing gastric acid secretion. It stimulates nearby parietal cells to secrete acid. It also potentiates the effects of gastrin and acetylcholine on acid secretion. Tegamet and Zantac or cimetidine and ranitidine block H2 receptors. This slide represents an overview of peptide hormone secretion as occurs in the GI tract. I have discussed this in this module so far. Take your time to go through this slide, listening to the audio, and as you become more familiar with the material, the slide will help to bring everything together. For example, looking at somatostatin, I've already discussed that it's a pan inhibitor. It's a pan inhibitor because it inhibits insulin secretion, cholecystokinin secretion, and gastrin secretion, as is shown in this slide. As a second example, cholecystokinin decreases gastric emptying and causes gallbladder contraction as well as release of bicarbonate from the pancreas, and this is also outlined on this slide. I would use the slide as a quick reference and a quick overview once you have familiarized yourself with this material. Neurocrines also play an important role in the gastrointestinal tract. The ones that we will need to be most familiar with are acetylcholine, norepinephrine, vasoactive intestinal peptide, GRP or gastrin-releasing peptide, enkephalins, neuropeptide Y, and substance P. I'm sure that you've come across acetylcholine and norepinephrine in the past in numerous different modules. However, vasoactive intestinal peptide, GRP, enkephalins, neuropeptide Y, and substance P are present in the GI tract, and you will not encounter them in other slides. The vasoactive intestinal VIP or vasoactive intestinal peptide relaxes GI smooth muscle, including the sphincters. It relaxes vascular smooth muscle, resulting in vasodilatation, and it stimulates pancreatic fluid and bicarbonate secretion. It stimulates water and electrolyte secretion from intestinal mucosa and inhibits gastric secretion. It also potentiates the action of acetylcholine in the salivary gland. The way to remember the activities of vasoactive intestinal peptide are that they often work in opposition to each other. VIP inhibits gastric secretion, and to potentiate this effect, it stimulates pancreatic fluid and bicarbonate secretion further lowering the pH. It acts as a relaxer of smooth muscle, both GI and vascular, and it potentiates the action of acetylcholine in the salivary gland. The stomach acts as a holding area for food and converts food to chyme. Small amounts of digestion occur in the stomach, mostly being protein. After the stomach acts as a repository, food is then released in a controlled manner into the duodenum and jejunum, and is under the control of different hormones such as cholecystokinin, as has already been mentioned. It's important to familiarize yourself with the different anatomic subdivisions of the stomach, as GI physiology is made much easier by understanding these different subdivisions. For example, in the antrum of the stomach, mucus cells and G cells, or gastrin-secreting cells, are present. In the same way, in the greater curvature of the stomach, we have chief cells which secrete pepsinogen and parietal cells which secrete intrinsic factor and hydrochloric acid. This will be referenced further during this talk. Gastric gland cells secrete about 2,500 ml of gastric juice per day. Mucus-secreting cells line the entire surface of the stomach and also secrete bicarbonate. The stomach mucosa has two types of tubular glands. These are the oxyntic glands and the pyloric glands. The oxyntic glands are located on inside surfaces of the body and fundus of the stomach. These contain parietal cells or oxyntic cells which secrete hydrochloric acid and intrinsic factor, and the chief, or previously known as zymogen or peptic cells, and mucus cells which secrete pepsinogen. The pyloric glands, which are located in the antral or distal portion of the stomach, secrete mainly mucus, some pepsinogen, and predominantly gastrin. Several glands open up on a common chamber known as a gastric pit. As you can see from this diagram, the chief cells, the enterochromaffin-like cells, and the G cells are all present, and the mucus-secreting cells are present at the top of the gastric pit. This becomes important because this helps to keep the pH of the cell surface at 7. The pH in the gastric juice is 2, but with these mucus-secreting cells at the surface of these gastric pits, it helps to keep a mucus layer which is rich in bicarbonate between the cells and the stomach contents, which are acidic. This therefore means that stomach cells themselves will not see a pH below 7 and are therefore protected from the extreme acidity present in the lumen of the stomach. Gastric secretion comprises of secretion by parietal cells, chief cells, G cells, and mucus cells, and they all interplay to produce an environment in the stomach which results in a low pH, as well as leads to absorption of certain vitamins, as we will discuss. Hydrochloric acid secretion occurs by parietal cells, and the H+ proton pump keeps gastric pH between 1 and 2. Omeprazole, which is a proton pump inhibitor, or esomeprazole, another proton pump inhibitor, inhibit the hydrogen-potassium ATPase exchange pump. And extrusion of bicarbonate can make urine alkaline. As it's shown in this diagram, this is an ATP-dependent process where hydrogen is released into the gastric lumen. This is facilitated by the fact that parietal cells contain carbonic anhydrase. This means that H+ and bicarbonate are produced inside the parietal cell. The hydrogen can be exchanged with potassium to be released into the gastric lumen, and bicarbonate is exchanged with chloride to go into the blood. This is the reason that urine can be made alkaline, and explains the postprandial alkaline tide that can be seen. At that time, there is more gastric acid being secreted, and therefore more bicarbonate being released into the blood as well. Promoters of hydrochloric acid secretion include acetylcholine, histamine, and gastrin. Acetylcholine is released from the vagal nerve endings and binds the M3 muscarinic receptor. It acts by causing intracellular signaling by IP3 and calcium, and is blocked by atropine. It acts via the GQ second messenger system. Histamine is released from ECL cells in the mucosa and diffused to nearby parietal cells. As has been discussed previously, it acts as a paracrine hormone. It's stimulated by H2 receptors, and intracellular signaling occurs via cyclic AMP. It's blocked by H2 receptors such as ranitidine and cimetidine. Gastrin is released by G cells in the gastric antrum into the circulation. It acts directly or via histamine secretion from enterochromaffin-like cells and results in activation of intracellular signaling by IP3 and calcium. Therefore, this diagram represents an overview of hydrochloric acid secretion. Stimulation of the vagal nerve results in acetylcholine secretion. This acts via the M3 muscarinic receptor, activates secondary messenger systems via IP3 and calcium, and results in acid release. In the same way, gastrin is released from G cells and acts on the CCKB receptor. Via the same second messenger pathway as acetylcholine, via GQ and IP3 and calcium, it also results in hydrochloric acid secretion. Histamine, which acts as a paracrine hormone, acts on the H2 receptor, and via GS and cyclic AMP results in hydrochloric acid release. Somatostatin and prostaglandins act via GI and cyclic AMP and act as inhibitors of gastric acid secretion. This becomes important because prostaglandin release is inhibited by nonsteroidals such as aspirin, and therefore can promote increased gastric acid secretion and therefore peptic ulcer formation. Pepsinogen and intrinsic factor are also released in the stomach. Pepsinogen is activated to pepsin by gastric hydrochloric acid at a pH of less than 5. Pepsinogen is secreted by the chief cells, and the vagus nerve stimulates pepsinogen secretion. Pepsin is therefore in its inactivated form, and H+ also stimulates local pepsinogen secretion, therefore acting as a positive feedback mechanism. Intrinsic factor is released from the parietal cells, which also secrete hydrochloric acid. Intrinsic factor is important because it binds B12 and is essential to B12 absorption in the terminal ileum by endocytosis. In the presence of intrinsic factor, B12 absorption can take place. If intrinsic factor is not present, then B12 absorption cannot take place. This is present in pernicious anemia, where B12 absorption is not occurring because of a lack of intrinsic factor. Small bowel resection with resection of the terminal ileum also results in B12 deficiency, but not due to a lack of intrinsic factor. In the last section, we looked at GI peptides and hormones. This section is very important as it's commonly tested in US unreleased step 1 examinations.